Welcome back to the all-new Step 2 version of 12 Days in March. And as a last reminder, here is the format. You should pause the recording and answer the questions. This will be followed by a question review, where we'll go over content and tips on interpreting NBME vignettes as described in the previous video series, Pearls, Pitfalls, and Lessons Learned. We'll continue to hammer away at the diagnostic algorithms, and all materials are summarized in the reference notes titled In a Word. And with this brief introduction, let's get started on Case 2, a 5-question series. Good luck. And here is vignette number 1. And part 2 of the same question. Here's a classic one for you. And another beauty. And our final question. And we're off. In this case, we're asked to make a diagnosis, and we quickly eyeball the answer options. So what do we have? They start us off with the very sudden onset of intense left knee pain in a 42-year-old. And not to interrupt your thought process, but the very sudden onset of intense joint pain already allows us to eliminate an answer choice. Although Lyme arthritis certainly presents with monoarthritis of the knee, when was the last time you heard it described as very sudden in onset with intense pain? And here comes the bait and switch from the question writer. He reports the patient just returned from a camping trip. I would remind you that verbiage like this can either represent important demographic information or tomfoolery for purposes of deceit. So the camping trip is likely included to lure the student into considering the erroneous diagnosis of Lyme, as we shall see. So it is probable the camping trip was just the venue for our patient to have a good old-fashioned alcohol binge, which may turn out to be an important piece of demographic information. We don't know that at this point. His vital signs are described as normal, and as we've already emphasized, negative information matters. So more likely than not, this information is provided to exclude septic arthritis, as we would typically expect a fever with a septic joint. And finally, the left knee is described as warm and swollen, confirming the presence of an acute monoarthritis. We are asked to select the most likely diagnosis based on this limited amount of information. In a case like this, if we don't know the correct diagnosis right away, out comes the old and familiar student refrain, I narrowed it down to 2 choices. In situations like this, it is good practice to work through our typical disease associations. And so what does that exercise look like? Here goes. What is the typical reactive arthritis story? Joint inflammation occurring days to weeks after exposure to a trigger, such as a GU or GI infection. It's reactive. It must be reacting to something, right? We'll cover this topic in detail during subsequent videos, but these patients generally have a myriad of other findings, including inflammatory back pain and mucosal symptoms. Since none of these associations are offered, I am comfortable excluding this answer option. Returning to septic arthritis, what are the typical associations? As mentioned, the patient is typically febrile, has some sort of risk factor exposure to the usual organisms, and vignettes almost always include a synovial fluid analysis. This is essentially required to make the diagnosis, as we'll see in part 2 of this scenario. So in the absence of definitive diagnostic information, we'll table this option, bearing in mind we are looking for the most likely diagnosis based on the information presented. And in this typical association exercise, I don't beat every option to death. Remember, 4 of the 5 choices are wrong, so I'll dismiss osteonecrosis as it doesn't typically present with an acute monoarthritis. And finally, we circle back to the correct answer, crystalline arthritis. I include my golden rule of reconciling answer choices before hitting the submit button. That means let's determine if it checks off all the boxes, or are there pieces of information that don't fit with the diagnosis. So let me first remind you that crystalline arthritis comprises 2 conditions, monosodium urate crystal deposition and calcium pyrophosphate crystal deposition. Both present with a sudden onset of intense joint pain. I would suggest to you that monosodium urate crystal deposition, more commonly referred to as gout, is often presented with known triggers, such as alcohol or culprit medication use. And so whereas any of these can cause knee monoarthritis, the scenario best fits crystalline arthropathy, which leads us to part 2 of this question. How do we confirm the diagnosis? To do this, we need a synovial fluid analysis. This will allow us to identify the characteristic crystals while excluding the presence of infection. That is, we rule in crystalline arthropathy and rule out septic arthritis. It's a twofer. And this brings us back to our diagnostic algorithm. We have an inflammatory joint disorder that is further defined and characterized through the synovial fluid. The NBME makes our job really easy. As for our other typical associations, I've listed some of my quick associations, and you should get in the habit of doing likewise. Although I'm not sure if any student selected a serum uric acid level, I would remind you that hyperuricemia predisposes to gout, but it isn't a diagnostic feature. That is, in a patient with an acute monoarthritis, a high uric acid level would not confirm the diagnosis. And here is the inflammatory synovial fluid analysis pattern seen in crystalline arthropathy. The WCs will be elevated into the thousands with a moderate percentage of PMNs plus the characteristic crystals. Students are generally well acquainted with the classic description of crystals as seen under polarized microscopy as shown. Alright, we just diagnosed our patient with gout based on demographic and physical exam features and confirmed the diagnosis with the appropriate synovial fluid analysis. Let's move on. Our next question had all the classic features of a gouty tophus, including a chalky discharge and two predisposing triggers for gout, including renal insufficiency and diuretic use. The graphic also shows a classic tophus, described as a non-tender nodule. Let's go on ahead and label this as a graphic you need to know. And don't kill me, but I've included the pathologic description of a tophus, including a granulomatous structure consisting of monosodium urate crystals. Remember, granulomas wall off or contain substances the body can't get rid of. It makes sense. So the question goes on to ask the most appropriate initial therapy. The mortar and pestle is meant to imply that choosing the correct therapies in gout questions is a major source of derivatives. So the correct initial therapy in managing a tophus is urate-lowering medication. I imagine we all did well on this question. Just to let you know, surgical excision is a possible option, but it wouldn't be the initial therapy. Methotrexate keeps rearing its head, as in the osteoarthritis case. In this instance, it was to lure the student into believing that this was a rheumatoid nodule. They are dastardly. I readily excluded ibuprofen and prednisone, as they are indicated as acute abortive therapies, not for the treatment of chronic tophaceous gout. And that brings us to probenecid, the only uricosuric agent available in the U.S. Do not fall asleep on this agent. Its unique mechanism of action makes it an NBME favorite, but not in this question. So why wasn't it the correct answer? Recall that the mechanism of action is inhibition of the organic acid transporters responsible for uric acid reabsorption. If the GFR is reduced, there aren't many transporters to inhibit. So it was the chronic renal insufficiency which was the relative contraindication. So the correct answer is allopurinol, and the teaching objective here was to recognize a tophus, the predisposing risk factors, and select the appropriate treatment. Let's continue. In this vignette, you were presented with a healthy 50-year-old with a classic onset of acute joint pain at the first MTP, and they show you a radiograph. On step 2, it is expected that you'll be able to identify an erosive arthropathy. So let's label this as a graphic you need to be familiar with. The description of rat-bitten appearance with overhanging edges is the language of gout on the NBME, and truth told, the appearance is classic, looking like a little rodent was nibbling on that bone. So we've made the diagnosis of gout based on the clinical presentation and the classic radiographic appearance. But now they want us to treat this patient to prevent further erosive damage. So we conjure up the purine salvage pathway and know that xanthine oxidase converts the xanthine metabolites into uric acid. So let's treat this guy with a xanthine oxidase inhibitor. Except for one problem. They didn't offer one. So we know we need to lower his uric acid level, but what are our other options? We can strike indomethacin and colchicine from the list as they are not urate-lowering agents. Methotrexate shows up again as a distractor in case you misdiagnose the patient with RA, another erosive arthropathy. So we are left with probenecid and pegloticase. Pegloticase is classified as a uricase agent that converts uric acid into the very soluble allantoin, which doesn't crystallize. The problem with pegloticase is the cost and requirement for IV administration. So let's take a look at probenecid before committing. In the last question, we saw contraindications to probenecid, but what are the indications? Well, here they are. Normal renal function, no uric acid stones, no significant drug interactions, and is it a cheap agent, making it the best first-line therapy in this otherwise healthy patient, at least on the USMLE. Don't fall for the trap that we don't really use it clinically. The boards don't care about your usual prescribing pattern. They only seek the truth. And finally, another treatment question, because they want you to know how to treat these conditions. And just to cut to the chase, here's how they do pharmacology on the boards. You make mental observations on your favorite drugs and indications, but then they give you a question stems full of all kinds of contraindications. So first we'll make a diagnosis, and they made it easy for us. They gave us a synovial fluid analysis with MSU crystals in a patient with an acute monoarthritis of the elbow. So we know the patient has gout, and here are our treatment choices. I do want to highlight they give this patient a low-grade fever, as can be seen in gout, but they really did it for purposes of deceit, so you might think he had a septic joint and choose vancomycin. But there were no bugs identified, and you have crystals. We are able to eliminate pegloticase and febuxostat, as they are indicated for the management of chronic gouty arthritis, not acute. So we are left with indomethacin and colchicine. And looking at the vignette, we can see it has a couple of contraindications to nonsteroidal drugs, including poorly controlled hypertension and peptic ulcer disease. And although we don't have a ton of information on that ulcer, please accept the question writer on their terms, okay? If they are mentioning peptic ulcer disease, they are screaming at you not to treat this guy with a nonsteroidal. Keep life simple. And that brings us to our correct answer choice, colchicine. We backed into this answer by default, which we have to do sometimes. And remember, this stem could have led to other derivatives such as mechanism of action or common adverse effects for the indicated agent. In pharmacology, be familiar with indications, contraindications, adverse events, and mechanism of action. They can go in any direction. Before concluding this presentation, I want you to be aware of two subtle but cautionary tales with the xanthine oxidase inhibitors. The first is that febuxostat now comes with a warning describing an increased risk of death compared with allopurinol. I can easily envision a question where you will need to choose between the two. On this basis, allopurinol is the preferred agent. The other noteworthy contraindication is in patients taking azathioprine or mercaptopurine. Both of these agents are partially metabolized by xanthine oxidase, so toxic levels can accumulate if used with either of these agents. And that's a wrap. In this presentation, we continued our categorical approach to the swollen joint, identifying triggers and predispositions to gout. We looked at the key diagnostics, including synovial fluid analysis and the radiographic description. We reviewed the complications of gout, including bone erosions and tophi, and we focused on the therapies, drawing the important distinctions between acute abortive and preventive therapies. The only curriculum item not reviewed in this presentation was the topic of urate nephropathy, which will be reviewed in the renal section. So I will slowly scroll through in a Word document. For those of you who don't have time or inclination to visit the website. Lots of great USMLE derivatives on gout. Again, this is a new series and format, so I encourage and welcome your feedback. Please send any and all comments, good or bad, to Howard at 12 Days in March. Many thanks and best of luck with your studies.